So thank you very much. It's always a pleasure to be here and seeing people from my past, seeing people with whom I have made relationships that I haven't seen for a while. And most of all, it's wonderful to see people in 3 dimensions, because you can only tolerate so much of a 2-dimensional Zoom screen. So it's wonderful to see that people in 3 dimensions. Just out of interest, how many people here have been in the organic acidemia or homocystinuria business, meaning personal business, in the last 5 years? Just to get a sense. Okay. Good. So I have been doing this for 30 plus years. I actually had intended to go into neonatology, newborn medicine, and but I decided, you know what, I should do a year of genetics and metabolism, because that'll be beneficial for newborn medicine. And then I got bitten by the metabolic bug, and I had a really good training situation at Children's Hospital in Boston. And so what would have been 1 year on my road to becoming a newborn intensive care doctor, 1 year became 35. So there you go. And it's patients that actually did that. I was a second-year pediatric resident at Sick Children's in Toronto, and we encountered a patient who had a metabolic acidosis. She had a GI problem, short gut, and she developed a metabolic acidosis. And of course, when you see that, the first thing you think of is infection. So I'm writing orders for blood cultures and urine cultures. And as I was writing it, it occurred to me, I don't have a backup plan if the cultures are all negative. And that's triggered me to go to spend this year. And so it's that little girl, whose name was Rachel, who got me thinking, who got me to pushed me to Children's in Boston, and changed my life. So it really is true that patients do change your life. But after I got into this field, it became very clear that it's patients and parents and families that really teach you everything you need to know. If you're open enough to listen and try to understand what they're saying and put things in context, then they really do teach you. And they also teach you not only about the disease, they also teach you about what's practical, what's doable. And so we have all these therapies, but sometimes the therapies are enormously burdensome. And it sort of, even though it might sound like a good idea, it pushes us to do better, because you are faithfully carrying out our instructions, and recommendations, but you have taught us what is doable, what is manageable, and what is not sustainable too. So this physician-patient bond is extremely important for you, but also extremely important for us. I also want to say that, as you know, there is a workforce shortage in this area of medicine. There's simply not enough of us, which unfortunately means that it's going to put more responsibility on you to be observers of your condition or your child's condition, and also to play more of a role in management, which might seem a little daunting, but it is the reality. And so the purpose of this session is really to sharpen some of those skills on your behalf, so that you can ask more questions and help you understand more of your management or your child's management, and anticipate things so you can push and ensure that you or your child continues to get the care that is important. So this is an informal session. So if there are any questions, please don't hesitate to interrupt me and ask. So let's begin. So the title of my talk is The Anatomy of a Metabolic Crisis. And it's about how it's really important to know the physiology. Yes, you need to know the symptoms. Yes, you need to know the milligrams of whatever medication, but it's really important to understand the physiology of what's happening, because that directs our care, and it should direct your concerns, your questions, and how you can intervene. So when we talk about a metabolic crisis, at first glance, people think of, organic acidemias have a metabolic crisis, urea cycle disorders have a metabolic crisis, fatty acid oxidation defects. Yes, those are disorders where patients fall apart. But, and the reason for that is they cause easy to understand and to monitor biochemical problems. High ammonia levels, low blood sugar levels, the blood goes acidic, or the opposite direction goes basic, and that's very helpful for us in terms of diagnosis and management. And homocystinuria isn't like that. It doesn't disturb that biochemistry in the body, but homocysteine elevations do disrupt, and they will cause complications of disease. In both situations, both the organic acidemias and homocystinuria have crisis-type situations because based on the complications of their disorder. Organic acidemias can go off into a full-blown ketoacidotic with crisis with high ammonia levels, and homocystinuria patients can go off and have a stroke or have blood clotting. These are acute crises, and often there are similar physiologic triggers that set off a crisis in either group of disorders. And they're similar. The organic acidemias and homocystinuria are both disorders of protein metabolism, and amino acids are the building blocks of protein. We use many of the same tests to identify the disorder, and there's overlap. And then there's some specialized testing for both groups. There are similar nutritional approaches. The basic theory of you want to reduce the offending amino acids, which can increase or cause the toxic metabolites to increase. You want to reduce that, so there's a dietary approach. And we use the same treatment considerations, the importance of calories and nutrition to keep patients stable. So there's actually a fair amount of overlap and connection between the two disorders represented at this meeting. So let's talk about protein. So protein is made up of amino acids, or building blocks of protein. The various combinations of amino acids differentiate one protein from another. And if you take each individual amino acid, there is a nitrogen carbon in the middle, and then you see an R group below the carbon. The R group can switch from amino acid to amino acid and differentiates one from the next. And it's not important from that standpoint to know about all the individual amino acids. I just want to emphasize that. And when those amino acids are degraded, each amino acid, depending on what it is, goes through its own pathway. So here is methionine, and methionine gets degraded in this way, and it gets degraded to homocysteine, and then it goes on down and down through the pathway. Now, I'll mention to you that, can you see this? So the methionine degradation pathway has a number of purposes. So for example, at the very bottom of the slide, you see it makes glutathione. Glutathione is very important for good immune function in the body. It helps with tissue repair. Because it's a potent antioxidant, it helps to reduce the effect of free radicals and the problems they have on the cells. So methionine degradation is actually very important. But sort of a little bit of a fun fact is if you follow the methionine down and to the right, and see it goes to 2-ketobutyrate. Well, methionine and threonine both form 2-ketobutyrate, and then they continue degradation, guess what? Through the same pathway as propionic and methylmalonic acidemia. It's the same pathway that goes through, and that part of the pathway ends up in the Krebs cycle, which is important because the Krebs cycle does a lot of things, central things for every cell function, including it helps in the production of energy. So there's both a physiologic and a biochemical link between homocystinuria and organic acidemias. So in that degradation pathway, just beyond homocysteine, you have the enzyme cystathionine beta synthase, and if that enzyme is disrupted, then you have classic homocystinuria. And one can also get elevated homocysteine levels if one can't go back from homocysteine to methionine, but that is a different kind of homocystinuria, and I'm going to put that aside for now because the disorders associated with elevated homocysteines, which can involve methylmalonic acidemia as well, the so-called cobalamin defects, they're a little bit of a different kettle of fish. Our approaches are different in terms of treatment, and so for the purposes of this talk, I'm going to focus mostly on the classical homocystinuria. So, in classical homocystinuria, what are we afraid of in the acute setting? Well, if their levels are too high, if the levels of homocysteine are too high in certain situations, then you're going to get clotting. And it's a major cause of morbidity and death, usually in the adult years, but there are probably a small percentage suffer problems in infancy or young childhood. And what you see is clotting mostly in the venous system, so deep vein thrombosis, so phlebitis in the back of the leg. You can get strokes, you get pulmonary embolism, and so on. You can also get clotting in the arterial system as well. It's not as common, but that does happen. And what kind of situations you often see it? You often see it in surgery. You often see it around general anesthesia, or especially the post-surgical area. Patients who are dehydrated are more at risk. Pregnancy for two reasons. One, because you have this big uterus that is interrupting flow from the legs, and therefore combination of homocysteine elevations and decreased flow puts you at risk for clotting. And then in the postpartum period as well is a high risk time for patients with homocystinuria. So that is the acute problems that we are concerned about in patients with homocystinuria. So let's now go back to this basic amino acid and talk about organic acidemias. So if this is an amino acid, and when that amino acid is broken down, the nitrogen component goes to the urea cycle. And if you have a problem there, that's the urea cycle disorder group. And what's left, once you take off that nitrogen, what's left is an organic acid. So amino acids and organic acids are directly related. And for amino acids, isoleucine, valine, methionine, threonine at the very top, those are four amino acids that sort of share this common degradation pathway. As I showed you before, the methionine and threonine actually come from different locations. They all come from different locations, but it's the methionine and threonine degradation that also involves the methionine degradation also involves the homocysteine pathway. But at this point, farther along, they converge on this final pathway. And in addition, you have other things that also contribute, but we're talking about amino acids now. So this amino acid degradation pathway, at the end of this, it also ends up in the Krebs cycle. And the Krebs cycle, again, is important for energy. So a major reason why amino acids are broken down is to produce energy. The protein, the amino acids are used as a source of energy by the body. Body doesn't only use glucose or fat, it uses protein and amino acids as well. So in this pathway, as you know, if there's the enzyme just beyond propionyl-CoA is a carboxylase enzyme, if that defect there results in propionic acidemia. Just beyond methylmalonyl-CoA mutase, if there's a defect there, that's methylmalonic acidemia. If you look at a different amino acid, leucine gets degraded in this pathway, and notice it also ends up in the Krebs cycle, so it's an important source of, it's one more pathway to provide a source of energy. And if you have a defect in isovalyryl-CoA dehydrogenase, that's isovaleric acidemia. And then finally, just to give another view on a different organic acidemia, so in the degradation pathway of two other amino acids, lysine and tryptophan at the top, you get this degradation, and off to the lower left, you see 3-hydroxybutyryl-CoA, which is a ketone body, again, a source of energy. And if you have a defect in glutyryl-CoA dehydrogenase, that is glutaric acidemia type 1. So, what are we afraid of in patients with organic acidemias? Well, in an acute crisis, they get into the problems of the classic crisis, the acidosis, the ammonia. They are at higher risk of infection because the organic acids suppress bone marrow function, so they are at risk for infections and bleeding. They can get into problems with pancreatic inflammation or pancreatitis. They are at risk for metabolic stroke. They can develop muscle tone and movement disorders, and they can certainly develop, in the acute situation, a cardiac rhythm problem. So again, features of the more classic metabolic crisis, but again, both homocystinuria and organic acidemias have crises. So the common link then is that patients are at highest risk of some acute complication, whether you have homocystinuria or GA type 1, when patients are biochemically unstable. So let's now talk about what do we as clinicians, and what I am sharpening your focus on is, what about the physiology puts patients at risk? So there's two major physiologic processes in the body: anabolism and catabolism. Anabolism means there is more energy coming from the outside than we need to fuel all the cell processes in the body. So what you see is all these chemicals, all these energy molecules coming in. Some are being used right away for energy purposes, but they also sort of join together and they form energy storage molecules. So glucose storage molecules are called glycogen. Small or fat is brought together and joined together to form long chains of fat, triglycerides, three fat molecules together, and it's stored away in fat tissue. And of course, amino acids form together to form long proteins. But when the body, when you're eating and you're eating sugar and you're eating fat and you're eating protein, the body treats sugar and fat differently than protein. If you eat too much sugar and fat, we store the extra, right? If you eat too much protein, your body does not store protein. Muscle is not a protein storage organ. If you eat too much protein, the body only uses what it needs, and all the rest gets degraded through those pathways that I showed you. Again, the extra methionine is going to go through the homocystinuria pathway. The extra methionine, threonine, isoleucine, valine will go through the propionyl-CoA, methylmalonyl-CoA pathway. So the body only uses what it needs. So during anabolism, when you're eating, if you eat too much protein, the extra is going to go through those pathways. So you gotta You got to set a limit on how much protein you eat. On the other hand, you have catabolism. And catabolism means you don't have enough energy coming in from the outside for whatever reason. And so those storage molecules start to break up and they release energy. And there are and there's a set of pathways for glucose where you break down glycogen or stored sugar, and it's called glycogenolysis, and you release that sugar and make it available for the body's use. Gluconeogenesis, different set of pathways that makes new sugar from scratch. Protein is broken down, proteolysis. Lysis means it breaks it down into its individual amino acids to use as energy. And fatty acid oxidation oxidizes or metabolizes these long chains of fat so we can use that fat as a source of energy. And now in those pathways that I'm just telling you about now, you have the classic metabolic disorders. So if you have a defect, a problem in breaking down glycogen, those are the glycogen storage diseases. If you have a problem breaking down fat, those are the fatty acid oxidation defects. If you have a problem breaking down protein, well, that's the amino acid disorders like homocystinuria. Or it could be farther along in the pathways. Once you lose that nitrogen, it's called the organic acidemias. So these are all catabolic defects. So it's easier to understand that catabolism is enemy number one of the metabolism clinic. It's not, yes, we're worried if patients eat too much protein. Yes, definitely. We are worried if patients get sick with an infection. Yes. But overall, if you look at the big scheme of things, it's catabolism in all its forms that push patients into crisis. Again, whether it's homocystinuria or whether it's an organic acidemia. So what kind of situations do we worry about, and I know that you worry about? Well, obviously, if a person is not getting enough calories, because they haven't visited clinic, the formula recipes haven't been upgraded, and the child or the patient has grown out of the recipe, of the prescription. And so they're not getting enough calories. That will slowly push a patient into crisis. If a person is fasting for too long, say fasting too long it comes for surgery scheduled to come in at 8 o'clock and the surgery gets canceled, and the child is not put on intravenous dextrose until, the surgery is delayed till 3 in the afternoon. Well, a patient can't remain stable for 6 hours or 7 hours without getting something. That puts a patient at risk. If a person is exercising too much or for too long and is not taking in calories in the meantime, you're forcing the body to use energy without supporting them and giving them extra calories. During infections, in order to fight an infection, we need more calories, not fewer calories. In fact, the old adage, feed a cold, starve a fever, makes no metabolic sense. Because what it is feed a cold, feed a fever more. Because with fever, for every degree of fever, you actually have to give maybe 10% more calories, because everything works harder in the body with a fever, which means you're using up more energy. The problem is, what is the human response to fever? We lose our appetite. So at a time when we actually need more energy, we actually have less appetite, and it poses a problem, especially for patients with, again, organic acidemias, homocystinuria, when you really, you don't want to get into a low-calorie situation. Surgery, trauma. The body's injured. It takes more energy to repair the body, and burns are the same way. Steroids. Steroids are naturally promote catabolism. Steroids kind of rev up the body. They also stimulate the release of glucagon, which releases stored glycogen to form sugar, and that sets off the catabolic cascade of all the other catabolic pathways. Eventually, if you have steroids and you don't support the patient, you can make them catabolic. Vaccinations rev up the immune system. there's more of a metabolic energy need, and some are associated with fever, and we've talked about that. And then newborns. All newborns lose weight in the first week of life. That is by definition catabolism, right? If you're losing weight, it means the newborn hasn't figured out how to take in enough calories yet. There's not enough calories in the breast milk, but in general, newborns start out catabolic. And that's actually why newborn screening is such a superb, or the timing of newborn screening is superb, because you have the newborns losing weight in the first week of life. That's when they're being discharged, generally discharged for the newborn nursery. And so they are heavily using their catabolic pathways. And so if there's a block in those pathways and you get an accumulation of substances, you're going to pick it up on newborn screening. So that's why newborn screening is highly effective in the newborn period. So when do we use when is a defective amino acid pathway being used? And therefore, when is the patient at risk? So if you take in too much protein, the body only uses what it needs. Everything else gets sent through those degradation pathways. Taking too much protein, that's why you can push these people into getting sick. And if you take too little protein or calories, and often the two are linked, if you're not taking enough calories, you're often not taking in enough protein, and the reverse, then your body's going to say, I need calories, and it's going to start breaking down glycogen, fat, and protein. Those amino acids are going to go through the same pathways. And that's when we see patients get into trouble. So we give you, you are often provided, especially if you have an organic acidemia, or if during situations when you or your child are most at risk, we often provide a protocol in the emergency room. And actually, I should make a side point. How many people here have encountered doctors in an emergency room who have not, who don't listen, or who have not responded to your concerns or recommendations? Okay. That you are not alone. This is not an uncommon situation. Doctors are human, and so some will be intimidated that you know more about your disorder than they do. And the truth is about rare disorders, once you find out about your diagnosis, your child's diagnosis, you know more than 99.9% of physicians, because learning about metabolic disease does not occur well in medical school and not in postgraduate training programs unless you're doing something like genetics and metabolism. So to them, homocystinuria was 2 paragraphs in medical school, and that's it. And so can you blame them for not recognizing or knowing what your concerns are? But still, one would hope that they would then want to hear as much as they can from you and learn from you. And often that's the case, but sometimes, as many of you have recognized, they are intimidated. And so they don't listen, and they go try to do their own research, and often that can be problematic, and it can certainly waste time. So that's why we provide protocols to patients, so that you have some official documentation with you that you can then provide to the doctor. You can stay in your parent or patient role, and hopefully they will follow. But if they don't, then this is what in general we recommend, is if the doctor isn't listening or is doing something that you think is either not fast enough or putting you or your child in danger, have them call your metabolic doctor. If they won't do that, then you call your metabolic doctor, tell them what's happening, and then what we will do is you'll tell us the name of the doctor. We will call back and start using words like stroke and sudden death, and that often pushes them along to listen because they don't want that to happen. And if this is a regular situation at your hospital, in your emergency department, then often metabolic doctors will then call ahead. If they know you're going to the emergency room, let the doctor know what his or her concerns are, and then hopefully they've cleared the road for you so you won't meet a lot of resistance. So that's my little spiel about emergency rooms. But so protocols that for organic acidemias and for homocystinuria in situations generally follow this. They, of course, they deal with the basic emergency concerns like making sure your airway is, you can breathe. That's basic. So airway, breathing, and circulation. And circulation is important because unless you are well hydrated, you can't get rid of, a patient can't get rid of ammonia as well, or a patient can't get rid of those organic acids which are intoxicating. And if you're not hydrated, the risk of complications with elevated levels of homocysteine are higher. So fluids, circulation are very, very important. Calories, all the protocols talk about calories, how to change anabolism, how to change a catabolic situation and make it anabolic. Because again, in a catabolic situation, you have more flux through those defective pathways, and those toxic intermediate compounds accumulate. And they often talk about nutrition, and we'll get to that in a minute. They'll talk about addressing the trigger of the situation, whether it's an infection, whether it's a fever, whatever it is. And then there'll often be patient-specific treatments for the organic acidemias, what to do in terms of treating the acidosis and homocystinuria, what to do in that kind of situation. But the key things that are in protocols are fluids and calories, and often nutrition as well. So what can you do? As a patient or as a parent, you have to be alert for situations that will trigger a crisis. So we've gone through, all the kind of potential situations, and to the best that you can do, you want to identify illnesses early. You want to anticipate problems like vaccinations coming up, surgery or procedures that are going to happen. Those are high-risk times, so you want to make sure that you or your child is prepared. So these kinds of situations, you want to anticipate and prepare. So what you can do is in terms of fluids. So why do we need fluids? Again, as I mentioned, well, just for basic stability, physiologic stability, heart rate and blood pressure, which during crises may be out of whack. It keeps the kidneys functioning to help excrete metabolic toxins and reduces the chance of blood clotting and stroke. So that's the need for fluids, as I mentioned before. So what you can do is start watching and monitoring for hydration or hydration risk. So if you notice that your child is not drinking well, then you know that after a certain point, that child is going to get into problems. So don't wait around till they're fully dehydrated and have to come in. That's worth a call to the ER, worth a call to the clinic. Let them know maybe it's the summer, maybe they have fever and they need more fluid. And so that might just require adding extra fluid. If they're sweating excessively, so that's a big loss, that's a big way of losing fluid, especially in the summer or hot environments. If you see urine output decreasing or getting darker, so a yellow, very yellow, or even amber urine suggests that the child is really trying, or the person is really trying to reabsorb as much water as possible, which is concentrating the urine, but needs extra fluid. And then if it goes too long and a person is dehydrated, they will go pale or even will go cool, and their peripheries become mottled. And so that's real evidence of a hydration problem. So those are the things that you can do in terms of watch or anticipate. And then what the things that you can do is, and it must be done in collaboration with your metabolic team, are things that you can increase the water or fluid intake at home. That we don't have to wait to get to the ER. You can do that either orally or through a G-tube. If you know how much fluid your child has not taken in because of vomiting or because they haven't tolerated formula, or if you know what the temperature is for every degree above 38 degrees Celsius, add 10% of fluids. These are things that if you know that, gee, my child should have extra fluid. This can be replaced over hours. It doesn't have to run in over an hour. It can be replaced over hours. And typically, if you look at your sick day protocols, which your clinic gives you, the sick day protocols often talk about increase during crisis situations at home when you're able to manage at home. There is often more calories in the sick day formulas, and there's more fluid to account for the problems that can occur. And of course, if these things can't be implemented, or if you're getting concerned, if you have any concerns, of course, you go to the ER. But these are things that can be done at home. What can you do as far as calories? Well, why do we eat calories? The more calories we bring in, the more we are anabolic, which means that the body's natural response is to be anabolic. You give enough fat, sugar, and protein, it will just continue to grow and maintain stability. Again, not too much protein, limit, but because catabolism is the most likely cause to get people into trouble. So you want to stop catabolism by giving more calories. So classically, what we do in the ED is, this is often a mantra for patients with acute metabolic disorders, give D10 with electrolytes at 1.5 times maintenance. What that means, give 10 grams of sugar in every 100 cc's of IV fluid, which is about 34 calories per 3 ounces of fluid. Run that in at 1.5 times the maintenance rate for that patient, which is based on weight mostly. And if you give that much sugar, then that will suppress the body's catabolism. Therefore, glycogen breakdown will slow down, protein breakdown will slow down, fat breakdown will slow down or stop. And therefore, there's less flux going through those offending pathways. So it's very effective. Now, the truth is, fruit juice is roughly, for 8 ounces, I think contains, I remember that it works out to be 12.5%. Most fruit juices have a lot of sugar. It works out to D12.5. So 12.5% dextrose as opposed to 10% dextrose. Theoretically, in milder situations, you can actually run the equivalent of what you get in the ER. You can run it at home. Again, you would never do it if a child is very concerning. You would never do it without your metabolic clinic, being on board, guiding you. But theoretically, you can give the equivalent of what you get in the ER at home. So if it's very early in a potential crisis, when a child is early on in an illness, has a fever, then your clinic may say, yeah, give more fluids and give more calories. So with this purpose in mind. Gatorade thirst quenchers is their product, is roughly about 6% dextrose, so not as high. You would get fruit juice because of the higher calorie content. And so what to do is, again, try to estimate, like fluid, how much calories the patient wasn't getting. You don't have to measure calories, you just have to tell the clinic, what formula wasn't taken, what food wasn't eaten. But we can use it, especially if they have a G-tube, we can push more calories that way. Again, you don't push it over an hour, you push it over several hours. And again, sick day protocols, if you look at them, there are often more calories than usual and more fluid than usual to get them over that hump. But again, calories, fluid, always consult with your clinic team first. And so, there is an argument against using sick day protocols at home because sometimes parents become a little bit complacent. They get used to minor crises at home and they intervene and they call the clinic. And then after doing it a few times, sometimes they stop calling the clinic and they just implement the sick day home protocol. That's problematic because there are situations then where patients end up going on a sick day protocol too often, and they end up losing weight and get into trouble because they've been without protein for too long. So again, always do these in collaboration with the clinic. And then finally, nutrition. And nutrition is kind of related to calories, but nutrition and calories have the same purpose. They will keep you anabolic and therefore reduce catabolism, which is a trigger of instability. We always want to promote nutrition. We never want to keep patients off protein, sugar, and fat for too long. But theoretically, you can feed through a crisis. A patient develops an infection and a fever, but they don't have any vomiting and any diarrhea. Theoretically, as long as they keep feeding and you keep them anabolic and the infection isn't too serious, you can feed through an illness without them decompensating. Again, close monitoring with the clinic to make sure that happens. But just because a child has an infection with a fever doesn't necessarily mean they always have to come into the hospital. But sometimes they are vomiting or they're not hungry and they won't take in what they need. And if they don't take in what they need or it's not tolerated through the G-tube, there is no choice. You have to bring them into the hospital because they need those calories in the form of often sugar to keep them stable until they can tolerate oral feeds again. So, and in that kind of situation, we often withhold protein for 24 hours. And, it varies from clinic to clinic. Some say 24, some say 36. And some don't even tolerate 12 or 24 hours. They never completely eliminate protein. And it depends on what protocol your clinic is following. But one thing is, you can't keep withholding protein. Protein is not the enemy. Too much protein can get you into problems. But protein is not the enemy. And if you stay off protein for too long, there is a calorie deficit that comes with that, and the body will start breaking down its own protein. And again, break down protein, and it goes through those pathways where you want to minimize flux through those pathways. So what you can do is always inform your clinic providers the last time you or your child tolerated food or formula. And so when we say that you shouldn't be off protein for longer than 24 hours, the 24 hours starts when the last meal was eaten or tolerated, not when the patient comes into the hospital. It's not the first 24 hours in the hospital. It's 24 hours since the last time the patient ate protein. And so it's important for you to have an idea of when you last tolerated protein or your child did, because they need that. And they may have to order parenteral nutrition, a little bit of protein in the IV, not like a regular formula, not like the protein in your regular formula, but enough protein in the IV to dampen, to not aggravate the instability, but to keep the patient anabolic. So again, this is some insight into how we think what we look for, how we gauge you or your child's physiology, and then we try to prevent and stabilize. There's no reason that you can't be part of that process. So the importance of understanding the physiology, being aware, watching for it, and then helping us so that we can help you. With that, I will stop and invite questions. So actually, I would say maybe the talk shouldn't be the anatomy of a metabolic, it should be the physiology of a metabolic crisis. Note to self. Okay.
Thank you so much. So I have a little guy with VMP, and you called us a different kettle of fish, which I like that. We're going to use that, I think, in the future. So my question is, I know that you were specifically talking about classical scenario when you're talking about a metabolic crisis. Do some of those symptoms and issues, maybe not on an acute or life-threatening scale, still happen with our following kids? Because some of those symptoms you were talking about, we see still maybe on a lesser scale. Do you ever see that widespread across these following disorders as well?
Well, so cobalamin A and cobalamin B is just isolated MMA. They behave like the organic acid, the more classic organic acidemias. Cobalamin E and cobalamin G can have, because of elevation levels of homocysteine, you have a very chronic situation, but you can have acute situations. It's just in that kind of situation with the cobalamin disorders, like all the disorders besides cobalamin A and cobalamin B, all the other cobalamin defects, you don't actually have, you have a high homocysteine level, but you don't have a high methionine level. And if you reduce the amount or limit the amount of protein those patients eat, you actually get into, because their methionine level isn't high to begin with, it's often normal or low, you actually deplete them of methionine, which is dangerous to the brain development. So the whole concept is calories are important, but we don't use a dietary approach. So, but in acute situations, yes, there is a worry. I would watch for hydration. I would, be aggressive. But in terms of the protein, that's sort of confusing, and so
Sure.
that's why I kind of avoided it.
Yeah, thank you for clarifying. And one of the other things that I noticed on one of your earlier slides of the pathways, you were talking about how methionine is then broken down into, I wrote it down, but I don't have my paper with me. But then it ultimately breaks down into energy, because I see with my little guy difficulty with energy maintenance. Like, he gets tired a lot quicker than my other kids. And so is that associated with, have you seen that with cobalamin disorders, or is
Yes.
my little guy just lazy?
Yes,
So,
I mean,
I'm just curious. So, yeah.
Yeah, so I think fatigue and low muscle tone is more prominent in the classic organic acidemias. But I would say, yes, that is true for these patients as well. It is because methionine is definitely a substrate for energy. I mean, it goes into that pathway. So if you see it, it could be very well in part due to the defect itself. Yes.
Okay, so he's not lazy.
Well, I didn't
Maybe
say
a little
that.
bit. Just kidding. Thank you. Anybody have any more questions? Because okay, I'll walk the microphone all the way over there.
Maybe you can walk the talk. You had a question.
Yeah, so you've already kind of hinted on kind of the lack of providers. One of the questions that came up is how much education do med students, residents get? And I know all about your education
outreach. So do you want to spend a minute talking about that?
So, medical students have a lot to learn in medical school. Competition for what they learn about is high. And so if you think about it, the academic source of metabolism is biochemistry. So meaning that metabolic disease is the direct clinical application of biochemistry. You show me a chemical pathway, and I'll introduce you to patients or families who deal with a defect in that pathway. It is a direct correlation. So starting back in 2007, when I was at Tufts, I started begging the biochemistry course in first year medicine, let me teach here. Not in genetics. Don't put me in genetics. Put me in biochemistry. And because biochemistry is pretty dry and pretty abstract. So what I started doing is bringing patients with defects in the urea cycle, defects in organic acid, homocystinuria, PKU. And suddenly, these aren't pathways anymore. These are people that have problems. And it became the best valued part of the course. And so we're trying to expand it. We have a patient-teacher registry for medical schools or medical centers that are interested in hearing from patients, having patients tell their stories. Because I can talk about a case, I can teach, I think I do a good job, but I can't do what you do, which is tell a story. Storytelling is an exceedingly powerful way of teaching because you add an emotional component. And it's that component that opens a portal and gets into their brain so that a month after the event, they don't remember who Mark Korson is and what he talked about, but he'll remember your story. So I in those kinds of settings, I try to push, I never teach alone. I teach in association with patients because I'm hoping that some of what I say sort of gets pulled in with what you say because you're going to open the portal into their brains and hopefully they'll remember some stuff that I say. So where possible, get out there and tell your story because they will remember you. There are many videos, patient videos on the internet, 3 minutes, 5 minutes, 12 minutes. And so we've actually developed a catalog of metabolic video links on the internet that are good teaching videos for whatever reason, patients telling their story. And we brought them together and now we're sort of there's something called the Association of Biochemistry Educators. There's that kind of an organization that has representatives from 140 medical schools. These are the biochemistry course directors. They're looking for ways of showing that biochemistry is relevant. And this shows that. So we're developing this so they can use it. They can download 5 minutes or they can have a speaker depending on how much time they have. They can download it and show how biochemistry is relevant, that these are not just academic biochemical pathways.